All right, welcome. Today, we're going to tackle two scenarios that are complete opposites, but are both absolutely critical in obstetrics. Labor that starts way too early, and pregnancy that just keeps going for too long. We're going to break down all the key concepts you need for your exams and for your clinical rotations.
So let's kick things off with a really common clinical picture. You've got a patient, 32 weeks pregnant, coming in with regular contractions. Now, your first gut instinct might be, we have to stop this labor no matter what. But is that always the right move? This is a huge point of confusion, and by the end of our talk today, you'll know exactly how to think through this.
Okay, here's our game plan. We'll start with preterm labor, what it is, why it happens, and how we manage it. Then, we'll flip the script and look at postterm pregnancy, its risks, and how we decide it's time to intervene. And we'll wrap it all up with a super high-yield summary of the points you just can't forget.
All right, first things first. Before we can talk about managing it, we all need to be on the exact same page. Let's get a rock-solid definition for what preterm labor actually means. So, the magic number here, the one you absolutely have to remember, is 37 completed weeks. Any labor that starts before that point is, by definition, preterm. This is a fundamental concept, and trust me, it's a favorite for exam questions.
Now, here's something that's really fascinating and honestly a little humbling for us in medicine. Even with everything we know, in about half of all cases of preterm labor, we can't find a specific reason why. It's often idiopathic, meaning we just don't know the cause.
But, while half the cases are a mystery, we do know about some major risk factors to look out for. And the single biggest predictor, the one that should always get your attention, is a history of a previous preterm birth. Of course, things like carrying twins, having infections, or other complications like preeclampsia also seriously ramp up the risk. Spotting these in a patient's history is absolutely step one.
So, what's actually happening on a biological level? What flips the switch and tells the body to start labor too soon? Well, it turns out there are a few main pathways that all end up at the same destination, as you can see right here.
This diagram really breaks it down nicely. You can see three main triggers. First, you have stress on the fetus, which kicks its HPA axis, its stress response system, into gear. Second, you have infections, which set off this whole inflammatory cascade. And third, you have the uterus itself being stretched too much, like with twins or too much amniotic fluid. The bottom line is, all three of these roads lead to the release of prostaglandins and other inflammatory stuff, which gets the cervix ready and tells the uterine muscle, the myometrium, to start contracting.
So, knowing why it happens helps us figure out what to do about it. When we decide to step in and manage preterm labor, we really have two big related goals. Goal number one, we need to buy some time. And the way we do that is with a class of drugs called tocolytics. Their job is to temporarily put the brakes on those uterine contractions. Now, the point isn't to stop the pregnancy from ever happening. It's really to open up a short but very critical window of opportunity.
So what do we do with that precious time we just bought? Well, this leads to our second, and you could argue our most important goal, giving antenatal corticosteroids. We give the mother steroids, like betamethasone, to speed up the development of the baby's lungs. This makes a huge difference, dramatically cutting the risk of respiratory distress syndrome if the baby's born early.
Here's a super high-yield way to think about it. Tocolysis buys you time, specifically that 48-hour window we need for the steroids to do their job. The corticosteroids then use that time to improve the baby's chances. These two things go hand in hand. Tocolysis is just the means to an end, and that end is giving the fetus a better shot at a healthy start.
Okay, so let's circle back to that question from the beginning. We don't always stop preterm labor. There are some very clear situations where trying to delay delivery would actually be more dangerous. These are the big contraindications to tocolysis. For instance, if there's a serious infection inside the uterus, what we call chorioamnionitis, or if the mom or baby are unstable, then getting the baby out is the safest thing to do. And generally, once you're past 34 weeks, the baby's lungs are in pretty good shape, so we usually just let labor continue.
All right, let's completely switch gears now. We've talked about labor starting too early. What about when it goes on for too long?
And just like with preterm labor, the definition here is key. A postterm pregnancy isn't just a few days past the due date. The official definition is a pregnancy that goes beyond 42 completed weeks. That's a specific clinical state with its own set of potential problems.
So why is this a problem? What are the risks? Well, it all comes down to the placenta. Think of it like having a limited shelf life. As it gets older, it can start to not work as well, a condition we call placental insufficiency. This can mean less oxygen for the baby, lower amniotic fluid levels, and a higher risk for some scary complications, like meconium aspiration or the umbilical cord getting squeezed.
Okay, so when it comes to management, it's really a balancing act. We have to weigh the risks of just waiting and letting the pregnancy continue against the risks of stepping in and inducing labor. Let's see how that decision gets made.
So the first thing we do is ramp up our monitoring of the baby, often with non-stress tests and checking the fluid levels. Now, if everything looks okay, the big question becomes, is the cervix ready for labor? If the cervix is what we call ripe, meaning it's soft and ready to go, we can usually move on to induction. But if it's unripe, still firm and closed, we have to prep it first. We use things like a prostaglandin gel to ripen it before an induction will even work.
And here's a really key point from current practice that you need to know. We don't always wait until the formal definition of 42 weeks anymore. To reduce the risks we just talked about, it's now very common to offer an induction of labor at or after 41 weeks. It's a proactive approach that we know helps reduce bad outcomes.
All right, that was a lot, so let's boil it all down to the most important, high-yield facts that you absolutely need to have locked in for your exams.
Let's talk about some common traps and points of confusion. First, not every contraction before 37 weeks means you give tocolytics. Always check for contraindications first. Second, remember, tocolysis is a bridge to get steroids on board. It's not a permanent fix. Third, the most common reason a pregnancy seems post-term is just a wrong due date, which is why that early ultrasound is so important. And finally, you can't just induce labor on an unripe cervix, you've got to ripen it first.
So if you're going to remember just a few things from this entire discussion, make it these points. First, know your definitions. Preterm is under 37 weeks, post-term is over 42. In preterm labor before 34 weeks, you have two superstar drugs, betamethasone for the baby's lungs and magnesium sulfate for the baby's brain. And for post-term pregnancy, remember two things. Offer induction at 41 weeks and keep a very close eye on the baby with regular monitoring.
At the end of the day, it's not just about dates on a calendar. Whether we're dealing with a pregnancy that's too early or too late, the real goal is always the same. Carefully balancing the risks to find that sweet spot, that optimal time for a healthy baby to be delivered to a healthy mother.
So I'll leave you with this question to think about. When you really understand why these things are happening, the inflammation in preterm labor or the placenta getting old in postmaturity, how does that change the way we monitor these pregnancies? It shifts us from just reacting to problems to actually looking for them ahead of time, and that fundamental shift from reactive to proactive care is what really saves lives.